how will organ transplant work? So we have, how come I can't give my kidney to just anybody? Or why can't I receive a kidney from just anybody? What if we are the same blood type? So let's say you and me, I'm B positive. Okay, so how do we know if we're compatible? What is the basis for uh, um, um, compatibility of between humans? Again, meaning, go back to Dr. Farrington. So in A and P, how does your body recognize itself another, from another cell? Meaning, how does your immune system work? If a bacterium or any cell enters your body, how does your body recognize that it's a foreign cell, a foreign substance?
Because it's
Because it's only your immune system that can recognize it and therefore will attack and destroy it. How do they do that? Do they have hands? Do they have eyes? Like, oh, Benjamin,
I think
you don't look like.
they're able to recognize foreign bacteria in a special way. Like
So they have eyes, they can see, oh, bacteria. They have microscopes, like, oh. So how do they know?
you have to do with they're able to.
Okay, so our cells, each cell in the body, doesn't matter what cell, has a protein signature, correct? On the surface of each cell are protein landing points, meaning there's a unique um, antigen on each cell, a protein antigen. We call that human leukocyte antigen. So that is like your ID. Okay, so whether it's a blood cell, your heart cell, your platelets, okay, so any cell in your body have a HLA. Your HLA is unique as your DNA. So all the cells, when it's produced by your body, have the same HLA. So it's therefore recognized by your immune system. They can recognize all self from non-self. So whenever your immune system cells, your white blood cells specifically, come into contact with another cell that has a different HLA, what will happen? Your immune system will be triggered, and then they will try and destroy whatever was encountered. Does that make sense? Okay. So therefore, the only two people or three people that have the same HLA will be identical twins, because you basically came from the same egg, right? So it's the same egg that split in two or three that became humans. All right. So the only perfect match will be, again, identical twins. Fraternal twins do not have the same HLA. So fraternal twins cannot necessarily donate organs to each other. Okay, they're not necessarily compatible, but identical twins are. So since how many of us here have identical twins? So if we're ever going to need a transplant, how's this going to work?
Difficult.
Okay, so we're going to have to settle with close enough. Okay, so we're gonna have to settle for close enough match. Okay, and of course that starts with blood type. So blood type matches. Next thing is the HLA. Is the HLA close enough? Right. So let's base our discussion on that. Now because we settled with close enough, it's not an exact match. Will the immune system therefore be triggered or activated once you transplant a tissue, a bone marrow, or a solid organ into somebody? Yes, because it's a different HLA. That thing is different. That's not the same as ours. So what will your immune system say? We'll destroy that thing. Okay, that's their one job, which is to destroy and kill, which is not their own. Okay. So therefore, what's the only way to keep an organ alive or to keep your immune system from destroying that transplanted tissue, cell, or organ? We have to we have to suppress your immune system. Okay. Now we don't have to suppress the entire immune system because you have to protect yourself from others. So, but there are specific cells in the immune system that are responsible for destroying other cells. Okay, so therefore, there are specific cells in the immune system that participate in organ rejection. So those what we will target with treatment. Okay, so let's discuss that. Now, there are 3 types of organ rejection. After months of careful planning, okay, so we looked at you're on the transplant list, you have been for I don't know how long, and then they try to match you with potential donors, okay, and then let's say you got lucky, somebody died recently, okay, let's say a car accident, and they happen to be a organ donor, okay, so hey, we got a fresh kidney, it matches your cells, okay, so a close enough match, so we're gonna do the transplant today, all right. So you're so happy. You've been on dialysis maybe for 10 years and then finally, oh, I'm getting a kidney. All right. So now we prepare. So we're going to have to suppress the immune system of the recipient. Okay. And if the donor was alive, then we'll have to do that. But here in this particular example, the donor is a cadaver now. Okay. So the donor just died. So no need to suppress a dead donor, right? But of course, if it's a living donor, so let's say just brain dead, but technically alive, we can do that. Okay, so we will suppress the immune system of the living donor. Okay, so that we have a very successful transplant. There are again 3 types of rejection. We will have to answer 3 different questions for each. One is, when does this type of rejection occur? Second is, what exactly happens? And then the third is, what can we do about it? I repeat, there are 3 types of rejections. We're going to have to answer 3 questions for each. 1, when is this going to happen? Number 2, what exactly happened? And then 3, is there anything that can be done about it? Notice that I did not include signs and symptoms because signs and symptoms would simply be signs and symptoms of organ failure of that particular organ that we transplanted. Make sense? So therefore, if we're talking about rejection of a heart transplant, what will be manifestations? Signs and symptoms of heart failure. If it's a liver that was transplanted and it's rejected, what will be manifestations? Signs and symptoms of liver failure. What about if it's the kidney? Signs and symptoms of kidney failure. Make sense? Okay. Now, what will be the manifestations? Well, it will depend on the type of rejection. Okay, let's start now. There are 3 types of rejection. There's hyperacute, there is acute, and then there is chronic. If it's hyperacute, what do you think will be the manifestations? Acute or chronic? Very acute. What about acute rejection? Also acute. And then finally, if it's a chronic rejection, what will be the manifestations? Chronic manifestations of failure. Because there's chronic heart failure, there's chronic liver failure, and then there's also chronic kidney failure. Yes? Okay, and then, of course, there is acute also for each of those examples. Let's start with hyperacute. Hyperacute occurs within 24 hours. So if a hyperacute kidney rejection, kidney transplant rejection, or hyperacute heart transplant rejection, hyperacute liver transplant rejection happens, where is this patient? Is this patient out of the hospital or still in the hospital? They're still in the hospital. Okay, they never left the hospital yet. Because can you leave after transplant? Can you go like, okay, do the transplant today, we'll discharge you by midnight. Did that happen? No. You're gonna be, yeah, you're gonna be there for several days, yeah, before we will let you go. So therefore, hyperacute rejection occurs when the patient is still in the hospital. Okay. When exactly does it occur? Within 24. Other textbooks say up to 48 hours. Since it's within 24 hours, can this also happen right there in the operating table?
Yes.
Yes, this can occur before we even close the incisions. Okay, it could happen right after we open the clamps and the blood starts flowing into the transplanted organ, and then it happens right there. Okay, so that's hyperacute. What exactly happens in hyperacute rejection? Okay, here's the pathophysiology. What happens is it's an antibody mediated reaction leading to generalized capillary thrombosis and necrosis. What does capillary thrombosis mean? What is a thrombos? Clot. And necrosis? Death. Okay. So therefore, if this is not one clot, okay, these are lots of clots. So if there's a lot of clots forming inside the capillaries of the organ that you transplanted, what will happen to blood flow to that organ? Is it just decreased or blocked? Totally blocked. So will it live? No. Will it become necrotic? Yes. So that's what happens. Now, can we prevent this? Yes, maybe. What did we do again? Did we just do the transplant like today and without any preparation? No, we did our due diligence. Okay, we tried very hard. We were very careful with the matching. Okay, preparation of both the recipient and the donor. Okay, we prepared them well. That way, we have a successful organ rejection. So what we can say here is this is just an unfortunate event. Among the three, though, among hyperacute, acute, and chronic rejection, this is the rarest type. I attended a symposium in Shands Hospital, that's in Gainesville, Florida. The kidney transplant doctor that I heard speak, he was only in his 30s. Okay, so he's fairly young doctor, but he's performed several because Shands is is a one of the best hospitals in northern Florida. So he said he's performed hundreds of kidney transplants. He's never seen one. So therefore, this is extremely rare. Okay, so he's only seen this in textbooks. And of course, other doctors may have experiences. That's how rare hyperacute is. You understand? Okay, because why is it rare? Because did we just do this transplant thing quickly? No, again, we were very careful. Okay, so we prepared again the patient and the donor well. So that's why this is extremely rare that it could happen. However, can it happen? Yes, but extremely rare. What can be done about it? Nothing. The organ is dead. So what will we do? Take it out, put it on the grill, eat it. That's all we can do. Yes? Yeah, we can eat it. You've eaten kidneys, right?
Not good.
Why not? Oh, just kidding, of course. Yeah. No, we don't cook it. Okay? All right. So any question on hyperacute? Okay, so now let's go to acute rejection. What is acute rejection? This one, when does it happen? This happens within a few weeks, so a few days to a few weeks, and sporadically also, meaning there's really no limit as to when acute rejection occurs. It can occur after 2 days, and it can occur at any time during the patient's life. And moreover, it does not occur only once. There could be multiple episodes of acute rejection. Again, I repeat, acute rejection occurs when? A few days after. 2, there's no limit. Anytime this can occur. And is it limited to one episode? No, this can occur again and again and again and again. Okay, so what exactly happens in acute rejection? Why are there multiple episodes? This one is because of a cytotoxic activity, meaning the immune system found a way to attack the graft. So the whatever cell, tissue, or organ we transplant, we call that the graft, by the way. Okay. And of course, the recipient is we'll call the host. Okay. So the host immune system managed to attack the graft. How? Well, you know the saying, what doesn't kill you makes you stronger? Yeah. Okay. So what did we do again after the host received the graft? What did we give the host? Immunosuppressant therapy. So we gave him drugs. Somehow, the patient's, the host's immune system found a way to fight back and then tried to kill the graft. Okay. So that's what happened. So what can we do? We can add more immunosuppressant medication, or we can increase the dosing. That's what we can do, right? Each time it happens, we're gonna do what again? Increase the dosage or add more medications in order to suppress the immune system. That's what we can do. The important thing here is early recognition and treatment. Okay, so each time it happens, the nurse is expected to recognize it early, because if you don't recognize the acute rejection symptoms, what will happen? This graft will be destroyed by the host immune system and then it's gone. Okay, so the patient is now back to status quo, as if they never got the transplant. You understand? So what's the treatment again for hyperacute? What did we do with hyperacute? Were you here a few minutes ago? So here, immediate removal of the transplant organ. What do we do with acute rejection?
Increase the dosage.
Okay, so here, treatment with immunosuppressant therapy. Now, the patient is already on immunosuppressant therapy. So what's the better answer here? What do we do? Increase or add more, right? Increase the dose or add more. Will this be a one-time episode? You survived one acute rejection? Yes, I survived. I kept the graft. Yeah, no more problem? It can happen again. Let's go now to chronic rejection. Chronic rejection is harder to manage. What happens in chronic rejection is it's the the process involved is because it's chronic rejection, and let's say uh think of the idea of putting a foreign object in your body. Will that foreign object eventually be accepted? Like, that'll become,
No. No.
no, forever it will be a target, right? Okay, so therefore, wherever you put it, will it cause some extent of inflammation because there's a foreign object in your body? Yes. So therefore, what happens to the blood vessels immediately around it when there's an inflammation? We discussed sepsis already. So the blood vessels around there will be, yes, sorry, inflamed, right? Yeah, swollen. So swollen, inflamed. And what happens to the lumen of a blood vessel, a capillary specifically, if it's inflamed? It will narrow, right? Yeah, because now if you inflame a blood vessel, capillary for instance, the walls will thicken, right? And then therefore, once the walls thicken, then that will narrow the opening, just like your bronchus. So therefore, what happens to blood flow, blood supply, oxygen supply to the organ? If there's chronic inflammation, it will decrease. So slowly by slowly, will that kill the graft? Yes, slowly by slowly, a few cells at a time, every day, every week, every month, cells in that organ will die. So was it like what happened before? That like how the patient lost the original organ in the first place? Yes, the same thing happens. Because it's chronic, it's slow, it's insidious. Can the patient notice the changes right away? No, it will take years for the patient to notice the deterioration of the organ. Once we see it though, once we recognize chronic rejection, is there anything we can stop that can stop the process? No. It's already being damaged slowly. So can we delay it though? Yes, we can delay it because it's caused by chronic inflammation. Can we give drugs to reduce inflammation? Yes. That's all we can do is delay the inevitable. That graft will fail again, but we can postpone that period by giving more medications. Those medications are usually going to involve steroids now. And what did we learn last week? When you're on steroids for a long time, what will you develop? Cushing what? Disease or syndrome? You'll have Cushing syndrome. And yes, Serene, you're correct. What are the consequences of Cushing syndrome? Peptic ulcer, right? So the patient will have gastric ulcers. Yeah. And then will they have osteoporosis? Yes, because of muscle wasting. Will they have edema? Yes. Will they have the moon face? Will they be at risk for infection? Yes. Will they have hypertension? Hyperglycemia? Okay. Will they have prone injury to the skin and also bones? Yes. All right, that's it for the three types of rejection. For management, since which of the three rejections can be treated? Acute, only acute? And we can treat hyperacute? What's the treatment for hyperacute? Okay, so acute and chronic can be treated. So the medications are the same. So regardless of the organ being rejected, whether it's a liver, an eye, a kidney, a heart, whatever else we transplant, a testicle, I don't know what else we transplant. The same drugs will be used. The list of drugs are on table 48-4. There are about three groups of medications. One group are called calcineurin inhibitors. So they are the immune system cells responsible for organ rejection are the helper T cells, the helper T lymphocytes. So that's why we target calcineurin, because calcineurin is responsible for activating T lymphocytes. So if you therefore inhibit calcineurin, then will T cells be activated? No. Will the organ be rejected? No. So we got tacrolimus, cyclosporin. Both of these are calcineurin inhibitors. We have mTOR inhibitor. This is another protein. This one will activate not only T cells but also B lymphocytes. Okay, so B lymphocytes are memory cells, and then helper T cells are like T lymphocytes. Okay, they do the same thing. So therefore, if you inhibit this with this drug, then no organ rejection. And then finally, this is the third group, anti-proliferative. Anti-proliferatives are actually also used in cancer, in chemotherapy. So chemotherapy drugs are anti-proliferative. So you'll see these drugs again later when we get to cancer. Among these though, among the three groups, the mycophenolate or the antiproliferatives are the cheapest. So you'll see most patients, especially those on Medicare, Medicaid, are on mycophenolate, okay, if they are organ transplant recipients. So their anti-rejection medication will be mycophenolate. But if these patients have a history of acute rejection, they'll be on multiple. They won't just be on one drug. But no rejection history, usually mycophenolate is enough. But once they have a history, then they'll be put on multiple now. Okay, so they'll be on more than one of these anti-rejection medications. For side effects, study per class, meaning all calcineurin inhibitors cause these, and all mTOR inhibitors cause these, and these are specific. Here, there's grapefruit interaction with sirolimus. There are drugs also that end in the same limos. There's tacrolimus, sirolimus, acrolimus. They're all mTOR inhibitors. So teachings, nursing responsibilities will be the same, right? For antiproliferatives, because these target WBCs, this will also cause bone marrow problems. So the patient will also have bleeding problems, platelet problems, as well as anemia. Okay, so that's the side effect of mycophenolate, because it acts on the bone marrow. Because where do you produce the white blood cells? In the bone marrow. So it doesn't has just affect white blood cells, though it will also affect red blood cells and platelets. And then also because your GI tract is single layer epithelium, meaning anti-proliferative means what? What does proliferate mean? To divide, right? Cell division. Okay, so for the cells to proliferate. So it's an anti-proliferative. Will it affect rapidly dividing cells? Yes, especially in your mouth. So from your mouth to your rectum, you may develop some ulcerations, and it cause GI upset, diarrhea usually. All right. These ones here are more expensive. Belatacept is more expensive. We don't see these very often, but they are in the market. This one is more, of course, all of these drugs, of course, cause neutropenia. Okay, so if you see commercials for any of these medications, they will all say, don't take if you have TB, or tell your doctor if you're prone to getting TB. Okay, because again, they reduce the immune system response, so puts you at risk for infections. Okay, all of them do, but the drugs that end in acept, which includes etanercept, okay, belatacept, these are more expensive, and they are specifically targeting cytokines broadly. So there are many cytokine medications. I mean, cytokine immune system cells. So we've got the not only for organ rejection, but also those that cause lupus, those that cause rheumatoid arthritis, okay, or Crohn's disease, or ulcerative colitis. So these drugs are also used for those purposes. Here's another Limus, okay, everolimus. Any questions on drug therapy? All right, that's it.